Let me just say something about what Gavi is. Gavi was established in 2000 as a innovative public-private partnership. The idea was to be able to take new vaccines that exist, that you got as a child, that we take for granted, and to make those available for children living in situations like you've seen. The idea is that these tools should be available to every child in the world. Gavi works in the 73 poorest countries. We work purely on economics. So if your country is below a certain cutoff line, they're eligible for Gavi. If they're above it, they're not. And it's an innovative model because we work on strengthening health systems with part of the finance we have, but we want to make sure this is sustainable. So every person who gets vaccinated, the country pays something for that vaccine. If you're very poor, they just pay a little bit. As they get wealthier, they pay more until eventually they get wealthy enough to graduate. Of course, the other side of this is that these vaccines are very expensive, and we've worked with the manufacturers to reduce the cost. And we buy vaccines for 60% of the world's children. And so by doing that, that allows us to be able to negotiate pricing, but also to now bring healthy competition in the markets. So Gavi's been around for close to 15 years now. It's been very successful. We've immunized now close to 500 million children, prevented more than 6 million deaths. And we're about to launch our next strategic period where we're going to focus not just on the new launches of vaccines that I've just talked about, but also on trying to reach the unreached, lifting up coverage, dealing with equity, and of course that means engaging with very fragile countries. Of course, you know, it's much in the news today dealing with infectious diseases, given what's going on with Ebola. All 5 of the Ebola-affected countries are Gavi countries. We've worked there to build up their immunization, and of course, now with Ebola, immunizations going down. And today, more children, more people are dying in those countries probably from vaccine-preventable diseases than are dying from Ebola. Now, of course, we have to stop Ebola so it doesn't overtake that, but just to give you an idea of the problem. And of course, Gavi will be looking at how we can work on trying to make available, ultimately, an Ebola vaccine if one proves to be efficacious. And again, we can talk about that if we want. What we're trying to do is make this a movement. We'd like every country in the world to be supporting immunization, both financially, but also psychologically, because at the end of the day, people travel and viruses travel, and what we want is a culture that says every child is immunized.
Hello everyone, I'm Ewan McGregor. I've been a UNICEF ambassador for 9 years, and I've travelled the world to see the work they do saving the lives of vulnerable children. On my last trip, for the BBC Cold Chain Mission documentary series, I travelled to India, Nepal and Congo, and I saw for myself the difficulties involved in delivering vaccines to children in some of the most remote parts of the world.
I thought the film was very poignant and told us a story, a very important story about getting vaccines out and following the cold chain. And he started out talking about polio. Of course, at the end, he talked about many other vaccines, and we can come back to that. You know, this is a challenge. In India, it's a particularly important place because India has the largest number of unimmunized, or I should say underimmunized children in the world. So even the most basic vaccines, about 7 million children in India each year are missing those basic vaccines. And a lot of it has to do with these issues of cold chain, logistics, supply chain, data, tracking people, having vital registration. All of those issues are played out in India. India has not yet rolled out the pneumococcal vaccine, which is for pneumococcal pneumonia. That's perhaps the largest killer of children. In most of these countries, it's either pneumonia or diarrhea. We're in discussions with India to try to get them to do that. But of course, with a birth cohort of 27 million children, there are issues related to cost and how it's going to be sustainable. And so these are important discussions we have with countries like that. Nepal, again, an important country, very good on work on health systems. Recently, they became the first Gavi country to introduce inactivated polio vaccine because we're at kind of the stage of polio where we're talking about the end game. And the idea will be to switch from oral polio to inactivated polio, and eventually to go from the trivalent, which is 3 different strains of polio, down to 2, down to 1, and then to stop the oral vaccine, because it itself can cause polio in rare cases, and switch to inactivated polio, and then eventually, when polio is eradicated, to stop that completely. So one of the things we can talk about in the discussion period is the challenge of how polio was eradicated in India, what they did that was right to eradicate it, and what a place like Pakistan is not doing now, and why there continues to be transmission there, which threatens the rest of the world.
I'm Andrew Jack from the Financial Times, followed global health for a long time. Great to be with you this evening. We've got about half an hour or so maybe ask you a couple of things, and then we'll open it up to the floor. Hopefully some fairly short but many questions from you before we wrap up at about 25 past. But Seth, I mean, you alluded to it there, and obviously the film talked about India a lot. Why don't we just talk a little bit about polio eradication, what India did apparently successfully, what Pakistan next door is still failing to do, and how that could change?
Well, it's interesting. So, can you hear me? Everybody hear me okay? Okay. So, when the original idea to eradicate polio occurred, and then there was a resolution in the World Health Assembly in 1988, what they talked about in that resolution was to strengthen routine immunization. And the idea was, if you got the coverage up really high, then most children would be protected. And of course, there might be some hard to reach children, so then you would do a campaign to reach those children. And of course, what happened over time is, as we didn't succeed in eradication, we would do more and more campaigns. And the strategy of trying to use campaigns to eradicate polio has worked in some places, but one of the challenges is, if you end up diverting resources from routine immunization, then you end up with more susceptible children, because children are being born every day, and so those children are unprotected, and that makes it much harder to eradicate. And so India made an amazing attempt to do really a few things. One is, they wanted to identify where people were being missed. So they began a very careful program in the weak states to map everybody. And they found large communities, large numbers of people, and they reached those. They also did campaigns to go out and track those down and get them vaccinated. And they did amazingly large campaigns where they did, sometimes on a day, more than 100 million kids. I mean, it's just amazing the scale that it's happening there with volunteers and others. But the other thing they did is they strengthened their routine immunization system. And so coverage in some of these low coverage states went up dramatically, and with that, susceptibility went down. And it was a combination of those effects that really made a difference, using sophisticated systems, using geographical positioning systems, mapping, and then being able to do follow-up. Pakistan is the country now that has the largest number of infections, and it's the place where the battle is going to be won or lost. There's still endemic infections in Afghanistan, but a lot of those are coming from Pakistan and in Nigeria. And Nigeria, though, had last year 6 cases, and there's some sense that that may be coming down, although there are areas under Boko Haram and others that aren't being able to get to. But in both of those other places, it's looking good. Pakistan has the problem of a huge opposition to vaccination, particularly polio, and there's a number of reasons for that. One was the issue related to using polio as a political entree around trying to find Osama bin Laden. But also, this is used because of the fact that many communities that are isolated only see polio workers. They don't see people coming with other vaccines. They don't see other health things. It allows them to stir up in the population, why are these polio guys here? You don't see polio in your community, and yet that's the only vaccine you see. And so there's actually been a killing of many polio workers. There's areas that have refused polio with tribal leaders, and now it's a matter of trying to separate that and get religious leaders to champion it, to use the army, which is the one stable institution, to reach out. And the hope is that with that, we'll be able to reverse it. But what we are doing in Pakistan is trying to strengthen the routine system, lift up coverage, introduce inactivated polio vaccine, which will go into routine, and hope that with that, in combination with the work that's doing, that we'll be able to end this epidemic.
And are you getting that sense, though, that it's shifting in the right direction? As you say, even before the famous bin Laden incident, there was quite a lot of hostility and resistance, and the progress wasn't great. The killings obviously have made things worse in some ways. Do you really think we're getting to a turning point now?
It's hard to say that. I mean, to be honest, and it's a challenge. Of course, we redouble the effort. One of the things that Pakistan did that's very interesting is there's a movement in global health to decentralize as a way to go out to, districts and provinces and have them be responsible for their health. Pakistan took it to an extreme. They actually did away with their Ministry of Health. And of course, that means for surveillance, that means for purchasing vaccines, that means for setting norms and standards. There is no central agency. And so we're dealing with some provinces that are quite strong, like the Punjab, which is able to do a lot of this and is doing better and is, working on this, but some of the other states that aren't as strong.
And you touched on this, but this question of verticalities, as it were, you almost got two there, haven't you? As you said, the difference between the focused polio campaigns, for example, compared to routine immunisation. And the second one, vaccination per se, as distinct from the health systems. And some critics would argue, obviously, maybe the focus on vaccines, great though it's been for prevention, has created a big weakness across pretty thinly stretched health systems in a lot of these countries. So, how far do you think Gavi and others are being able to address that and really try to provide something more effective and integrated that doesn't risk, causing problems to come up in other areas?
Yeah, it's an interesting question. Of course, forever in this history, there's been this debate whether we do horizontal programs or we do vertical programs. And of course, people who work in the field a lot say we should do diagonal programs. It's a little of both. So from my perspective, the critical issue is you need an intervention that is cost effective, that makes a difference, and that will be able to save lives. And certainly immunization meets all of those. With that, we build a system. Now, immunization is the intervention that reaches more children than any other intervention on earth. So if you think about that, more than anything else, this is the one that reaches the most. In doing that, in building the systems to do that, we put together basic infrastructure. We work to create health workers. We work to create systems and clinics. And that is the base of the public health system. So I think that, do you need more investments in health systems? Absolutely. We spend between 15 and 25% of our resources on strengthening health systems. We spent $53 million in the 5 Ebola-affected countries before the outbreaks occurred, not enough to make the resilient systems that would have made a difference. But it's an important part of what we do, but it's also, at the end, the base for all of the other building that occurs. And lastly on that, the Lancet Commission on Global Health, which came out last December, talked about the fact that the way to think about moving forward for kind of the world is to make sure that there's universal access to health, but they talked about progressive universalism. And the idea is that you just can't have everything everywhere because you'll end up with a veneer that doesn't work. And the idea of progressive universalism is that you start off with the things that are cost effective, that'll make the maximum difference, and then over time, as you have more resources, you do more and more.
Really, with regards to the cold chain, I am interested to know just what the wastage is. Watching boxes being trekked across mountains on the back of a donkey causes me great concern, and I'd very much like to know, is the wastage recorded? Is this something that you have as a problem in terms of the immunisation of these children in such remote places? Yeah, thank you.
On the cold chain, this was a very specialized thing. He was doing it to show effect. Most places aren't quite as isolated as that. And the answer, the honest answer to wastage is we, of course, keep records. We, of course, can tell you statistics, but you don't really know. And it's one of the reasons that thing he showed you, that's a vaccine vial monitor. That is a tool to show if the individual vial, of course, goes out of range for temperature. But there's also been a movement to make vaccines that are more tolerant of heat. And some of the vaccines now can go out of the cold chain for as much as 4 days. They're certified for that. They probably could do more. And then finally, the other thing is to create a system that the entire cold chain is being mapped as well. And we're now putting in systems that allow those to be monitored externally. So when there's a deviation in cold chain, it can send a text message to somebody's phone to do that. Now, this is a slow process of modernizing these systems. And in an ideal world, we'd have vaccines that didn't need cold chain. But I think, for now, it's going to continue to be a reality.
Okay. Moving over that side, please.
In light of the recent Ebola outbreak and then other emerging infectious diseases, what is Gavi doing and working with pharma and other donor countries to accelerate the process of getting candidate vaccines up to market and into the field?
So on Ebola, you know, in a sense, the tragedy on Ebola is that the good news is there are now vaccine candidates that are in humans, and there's a number of others that are coming behind it. The bad news is that those were not developed for the countries that have the outbreaks. They were actually developed as part of a worry of bioterrorism, and knowing that Ebola was a particularly lethal agent, it was one of the agents that was picked to make vaccines. And these vaccines have been around for close to 10 years now, and they just haven't moved very far. And part of it is that there's no market for anybody to develop this, a private company to develop it. And there also was the difficulty of how do you test it, given the fact that the outbreaks occur sporadically in different places. And so now, with the outbreak, there's been a huge attempt to try to accelerate these. And these normally would take 5, 6, 7, 8 years to go through the whole testing process. The trials, you know, the UK, for example, launched a trial at Oxford, a few weeks ago. The regulatory agency did the review of that trial in 4 days. Now, I've done a lot of trials in the UK, and I can tell you that the normal regulatory turnaround is not 4 days. And so we're now seeing what the world can do if they really push. And there's a discussion to say that, you know, we can have efficacy data kind of, you know, end of first, beginning of second quarter of next year, which would be an unbelievable compression of the timelines. So what is Gavi doing? So we're talking to all of the companies. There's been a push on the research side, and there's a lot of research agencies that want to get vaccines out and move them forward. What hasn't had so much of a discussion is, what do we do if we have a successful vaccine? How do we scale it up? How do we go ahead and get it fill and finished and ready for use? What's going to be the scenario at that point? Best case scenario, Ebola's controlled with the big push now. You know, we don't need it. That would be great. What if it goes the other way? What if it spreads to other cities and it explodes? And, you know, then we need millions of doses, tens of millions of doses. If it does go away, how do we make sure there's a stockpile that's put together so that there is a future outbreak, we have vaccine available? So those are the types of issues that Gavi is going to be dealing with. And we're working with the manufacturers to understand their needs, and then we'll go to our board with a plan on what can happen during this period. I think the critical question, if you want to know the one thing, is going to be, do you invest and scale up on vaccines before you know they work? So, you know, and part of that depends upon a perception of how bad things are. You know, from my perspective, we do a lot of things, particularly around the military for protection, where we spend massive amounts of money for things that we don't think are going to happen, but just in case we want to be protected. So the question is, you know, how do we value that? It wouldn't be, in the big picture of the world, a lot of money to go ahead and take each of the vaccines that are now in clinical trial and the one that's behind it, or maybe the one behind that, and to go ahead and do that work. Even if they didn't work, it wouldn't be a huge loss. But again, if the worst case scenario is, you know, a very, very fast spread, more severe disease, you'd be awfully happy if you could have cut some of the time off. So those are the types of debates that are going to have to happen going forward.
I have a question on the data and monitoring of activities on the ground and the investments in that strengthening part of the chain for Gavi. As an individual, if I'm choosing to invest, or as a country, I'm now getting diagnostic companies saying, I can tell you where I did a CD4 test, I can report to you the CD4 count instantaneously. There's real live time mapping. I wonder if there are any innovations that can track immunization records.
In terms of the data investment, we are trying to modernize. It's a critical component, and there's many ways to look at it. We have a program called the Full Country Study, which we're doing with IHME, which is the Institute for Health Metrics and Evaluation in Seattle, but then in 5 countries with local institutions. And the idea is to innovate in understanding what's happening in the countries, and to have it be a proactive evaluation that's real time, rather than something you do after it's over. And they're looking at using different techniques, surveys, cluster surveys, small samples, but also biomarkers to see if you could use that as a way to validate findings and validate card things. They're also looking at, verbal autopsies and other techniques. And the idea is to get as close of an understanding of what's happening, and then are those techniques relevant to be used in the broader range of countries. So that's going on now. In addition, we're doing other things like right now vaccines aren't barcoded. So, when people want to track them, they write down the code. So, given the fact that we purchased 60% of the world's vaccines, we initially experimented, and now they're going to be required. So we're going to have barcodes on vaccines, or at least on the secondary packaging. And so now there's no barcode readers, there's no data systems. It was a little chicken or egg problem, but we're now working with companies to try to figure out how we will set up systems that can be used to track the stock going out, which will be very important, because if you run out in an area, you don't have to call up Copenhagen to ask for more doses. You could ask, well, is there vaccine available in a neighboring community? And it would allow you to, more carefully control stocks, deal with the wastage issue that somebody talked about before. And so these are important innovations that we're trying to work on now.
And do please thank Seth for the meantime.